we have got our Elizabeth Madam, none other than Elizabeth Madam, for discussing the case. On behalf of IAP Kottayam and IAP Kerala, I extend a warm welcome to Elizabeth Madam, our senior faculty for the day. And I also welcome Joe Sir, our IAP President, Kerala State Branch President. And also I welcome Basavaraj Sir, who is the past secretary and the President-elect of IAP towards this program. I also welcome all our senior faculty members who are joined for this session. And last but not the least, I welcome all the postgraduates who are to join also to this wonderful program. So over to you, Joe Sir. Joe Sir, please.
Okay. Thank you, Dr. Suresh, and thank you, the IAP Kottayam, and Dr. Murari and Anush, and ICH HOD, Dr. Dali Madam, and our state convener of the program, Dr. Shanawaz Sir. And today, the leading faculty, none other than our teacher of teacher, Dr. Elizabeth Madam. And today, we are blessed with the presence of our President-elect of Central IAP, Dr. Baswaraji. And all our past president, Dr. Santosh Sir, and all the faculties joined here, and all the postgraduate students. We are regularly conducting this program, and coordinated by Dr. Shanabas Sir, by different branches every Thursday. I think every week there are increased number of participants for this program. I think this is a golden opportunity to the PG students to get a knowledge regarding the discussion regarding the cases by the expert faculty. And today, none other than our mother of nutrition, Dr. Elizabeth Madam is there. So the madam is conducted the 6th June, the complimentary feeding week celebration in extensive manner. Madam started with the talk on regarding the feeding, complimentary feeding which was a enlightening for all the postgraduate students and all the PGs, all the academicians are benefited by the madam's talk. And again, and madam arranged a wonderful feast of academics on that day. I very much appreciated by the IAPNs from Kerala, and outside Kerala is also benefited by that program. So I think today the program is one of the important topic of our new generation is concerned, and obesity, the extremes of one extreme of our nutrition issues, obesity, we are going to discuss. I think this program is also we have to discuss. Everybody should know how to approach a child approaching with obesity in our day-to-day practice. And with these words, I wish you all the best program, and Jai Hind, Jai IAP. Over to Dr. Suresh.
I request Darli Madam to introduce the topic. Darli Madam is the mentor for today's session, HOD ICH Kottayam.
Good evening, everyone. Respected Elizabeth Madam, Dr. Jose, IAP President and Kerala State Branch, Baswaraji, the President-elect of CIAP, and all the dignitaries in the platform. This is actually an OP case picked up from the OP, and it is very interesting to see that boy and also the history. That is why this is taken as a case for today's discussion. And we were waiting for the madam's date, actually. This is madam's date. And we were also planning for a case of nutrition to be present in this platform. And luckily, we got this case, and we are happy to present this case. And Dunia is ready with the case.
I think before going to our topic, our Baswaraji sir. Sir, Baswaraj, can you unmute and say a few words? Dr. Baswaraji. Yes, I think he is muted, and okay, we can proceed. Shanawaz sir, a few words.
Sir,
you can call him on the phone.
I will call it.
Call him on the phone.
I will call in between. Shanawaz sir.
Very good evening to all. Respected Elizabeth Madam, IAP State President Jose Sir, and officials of IAP Kottayam, and my dear friend, I'm very happy to be a part of this golden program of IAP PG teaching program under the auspicious guidance of Dr. Jose Sir. So we are regularly conducting these topics, and the last 2 weeks we were discussing regarding newborns. So already our MD examination has announced, and will be conducting from July 17th onwards, so that nutrition and also newborn programs, newborn cases are very important for examination point of view also. In such a way, Kottayam has selected a case related to nutrition, and I express all the best for the topic and for the case discussion. Thank you. Thank you all.
Thank you, Shanava sir. Basavaraj sir, can you please unmute and speak a few words? Basavaraj sir.
Sir, വിളിച്ചോണ്ടിരിക്കാൻ തോന്നേ.
Okay. Duni, are you ready there now?
Yes, sir.
All the best wishes to you, and hope you will have a good learning experience out of this case. And I also request, who are the other PGs along with you, Dunia? Can you name a few for madam who are attending this from Kottayam?
Rahul.
Yes.
Chinnu.
Yes. You just adjust your camera. Your face is only half seen. You just adjust the camera of your laptop. Okay, thank you.
Okay, we can proceed. That is not our president-elect, some other Basavaraj. Not our.
Okay, Joseph. Thank you for that information. We will continue with the session. Over to Elizabeth, madam. We will start our session. Thank you, madam.
I hope I am audible.
Yes, madam.
So,
Yes, madam.
Thank you very much for this great opportunity. I'm always happy to be with the Kottayam team and IAP Kerala. Even though now I'm working with MGR University, Tamil Nadu. So I'm very happy that team IAP, Dr. Jose, Dr. Krishna Mohan, and the coordinator, Dr. Shanavas, along with Dr. Dali Mavan and the team IAP Kottayam, Dr. Murari, Dr. Anush, and we have a lot of seniors and learners and postgraduates here. So I'm very happy that you have chosen this case. Now, our big problem is not ma'am and Sam, but obesity. And obesity with disguised in different manner. So I was also really, I'm perplexed to see this child's history. So, and Dr. Dunia has done hard work and she has prepared it. So let us listen to her, this case, which is a different case of obesity. Over to Dr. Dunia. Dr. Suresh also has been toiling so hard for this program, the success of this program.
Dunia, you can now share your screen and start the presentation. Elizabeth, madam, we have Chinnu, Rahul.
Chinnu and Rahul are the learners. Okay, good.
Okay, yes.
Okay. Our past president, Dr. Sandosh, is also here. Okay, you can present.
Presenting the case of a boy, 11 3/4-year-old boy from Changanasheri. His complaints are increased appetite for the past 3 years, increased weight gain for the past 3 years. This is the current photo of this boy. And this is his old photo, which was taken nearly 3 years back. History of present illness. Child had apparently normal physique till 8 years of age in 2019 and was noticed to have increased appetite and increased weight gain for the past 3 years since the onset of COVID pandemic and has further aggravated during the summer vacation. There is history of poor physical activity along with increased screen time, which is nearly 10 to 12 hours with snacking while watching TV. There is history of intake of milkshakes, fruit juice, junk food, and added sugar in excess along with daily meat and fish. History of taking second servings, and he had history of aggressive behavior if denied of food. History of eating nearly 2 hourly while at home during vacations, and he skips breakfast on going to school. And has decreased intake while at school, which is compensated in the evening. There is history of being bullied by peers, due to which he avoids outdoor games. There is history of difficulty in walking with thighs rubbing against each other, resulting in skin exfoliation. There is history of breathlessness on walking and climbing stairs. There is associated on and off frontal headache for the past 2 months, which is lasting nearly 30 minutes, 1 to 2 episodes per month, with no associated vomiting, photophobia, phonophobia, or blurred vision, and which got often relieved by paracetamol. There is history of snoring with no history of disrupted sleep or daytime sleepiness. There is history of urinary and fecal incontinence on crying with bowel movements, which is usual, twice daily, with no history of any constipation. No history of bedwetting, increased urine output or increased thirst. No history of anxiety, school absenteeism, or poor school scholastic performance. No history of lethargy, cold intolerance, or constipation. No history of any abdominal pain, back pain, or knee pain. No history of any drug intake.
Okay. So you have presented his history and you have shown us his physique before and after. So I would like to ask Dr. Rahul and Dr. Chinnu. So in the history, what are the factors? Now, you know that this is a case, all of us are telling this is a case of obesity. So what are the factors that has led to his obesity? Dr. Rahul and Dr. Chinnu can answer.
Madam, it's a lifestyle like that. Is a decreased physical activity, increased sleep also decreased, screen time also is there, increased, and has probably.
So it is not one reason, no? In this boy,
Yes,
it
madam.
is not one reason. That is what I want to say. One is the COVID pandemic, and all children were having lockdown, no?
Yes, ma'am.
So every child was eating too early and was having TV, increased screen time. So many yes, you must say. Apart from the pandemic, sedentary lifestyle, then increased screen time, decreased sleep, decreased sun exposure, and sugar sweetened beverages, isn't it?
Yes, ma'am.
And so much of sharja and milkshakes and sugar sweetened beverages. Previously, this unhealthy food was only available outside our kitchen. But during the COVID season, through YouTube, all these came to our kitchen. That is it. And most of the boys and girls started going to the kitchen and preparing their own things. And after that, what is the new S? When the lockdown was lifted, the Swiggy started, Swiggy and the Zomato, no? All S happened to be the disadvantages for this child. So everything like that. Plus anything more you have observed? He's snacking, that is S. He skips breakfast, that is very important. How does skipping Sanishma, you should be muted. Huh? There is noise from her phone, from her device. So how does skipping breakfast increase obesity? We say that a healthy eating is that breakfast like a king, lunch like a queen, and dinner like a pauper or a beggar. Very less. But what happens in skipping breakfast? Most of us now eat maximum at night and skip the breakfast. So skipping breakfast, what happens? It is actually a metabolic stress for your body, no? After 8 hours or 12 hours of fasting, the body has to find out the energy. It is not readily available because you are not taking like a reserve petrol. You are going with reserve petrol, you are going for the schooling or physical activity. Then those who skip breakfast tend to snack more and they overeat during lunchtime. They say, I didn't have breakfast. Always we say, I didn't have breakfast. So let me eat. That will be the craving. So that is why the skipping breakfast. So many S are there in this child's history, which is making him so much overweight. Okay, now Dr. Dali wants to add something, or you must add in between. Huh? Okay,
Nothing more.
continue.
Continue.
Past history, no prior hospital admissions, no past history of any head trauma or surgery. Antenatal history is the first child of a non-consanguineous marriage, spontaneously conceived at 27 years of age and had regular ANC. First trimester was uneventful, no history of any hyperemesis, fever with rash, drug intake, radiation exposure, spotting PV or UTI, injection TT and folate.
Are you using two devices? Are you using two devices? Then switch off one.
Injection TT and folate tablets were taken. Rating scan was done. Second trimester, quickening was felt at 5th month. No history of any gestational diabetes mellitus, PH or bleeding PV. No history of any decreased fetal movements. Iron and calcium tablets were taken. Anomaly scan was normal. Third trimester, no history of any GDM, PH, bleeding or leaking PV, UTI or diarrhea. Appreciated fetal movements well. Weight gain during pregnancy was nearly 14 kg. Her pre-pregnant BMI was 25.7 kg and growth scan showed increased fetal weight.
So can you tell us why you have brought out this point, pre-pregnancy BMI?
Madam, there is a, depending on the pre-pregnant BMI, there is adequate, the recommended weight gain is being shown in the next slide. For this lady, she is overweight. According to her BMI, she had a pre-pregnant BMI is 25.7, which means she's overweight.
That means,
so her recommended
we have a learning point, that is previously we were taught and still we are teaching that 10 to 12 kg weight gain is adequate during pregnancy. But you go to the next slide. So according to this, as way back in 1999, weight gain during pregnancy according to pre-pregnancy BMI was suggested, and in 2009 it was revised. So her BMI is 25, no?
25.9.
So for Asians, 25 to 29.9, that is overweight. For Asians. Okay, even 23 is overweight. So she is in the overweight side, and for her, it should have been between 7 to 11.5 only. So 10 to 12 for every mother is not what we should be teaching. And an obese mother who has a BMI more than 30 can have only 5 to 9 kg weight gain. Otherwise, the baby will have overweight. And increased fuel excess in utero is one of the reasons for future obesity and
cardiovascular complications
and adulthood diseases. What is the other part of the story? What is the other one? Rahul and Chinnu also can answer if you know. So one is fuel excess. The second is fuel deficiency in utero and postnatal overfeeding.
Overweight.
My baby is so low birth weight, or we also say baby should have more weight. So there will be postnatal overfeeding. So this mismatch in fuel deficiency in utero and fuel excess postnatally and postnatal overfeeding. These are all
increased risk of cardiovascular
of obesity.
Obesity and cardiovascular, according to Barker hypothesis.
Okay. So usually it is a J-shaped curve. When you speak about a risk factor, there is no risk factor for some time. Then at a threshold, the risk factor will go. But when it comes to birth weight, it is a U-shaped risk factor. You can see a small U there. That is, lower the birth weight and higher the birth weight, the baby is at risk of developing metabolic syndrome and early onset of adulthood diseases, including obesity. And now we consider obesity as the mother of all NCDs. Obesity is the mother of all NCDs. Okay, we will continue.
Natal and postnatal history. He was born by full-term vacuum delivery at TMM Tiruvalla. Birth weight was 4.250 kg. And there is no history of any perinatal asphyxia, no history of any birth injuries.
So
Postnatal,
he is LGA baby, no?
yes, he
What
was
is macrosomia? What is macrosomia?
more than 4 kilogram weight, birth weight more than 4 kilogram.
4 is LGA. Actually, that is LGA. 4.5 is macrosomia. Dr. Ria has answered 4.5 in chat box. So the participants can also answer in chat box. Okay. So this is LGA and macrosomic is 4.5. And usually we have them with GDM mothers, no?
Yes, ma'am.
Yes. Continue.
Postnatal history, he was breastfed within an hour, was feeding well, passed urine and meconium on postnatal day 1, history of NICU admission on postnatal day 3 for NNHB, and phototherapy was given for 2 days. He was discharged on postnatal day 7 on breastfeeds, was not given any top-up feeds.
So that part was good, no? IYCF practices were good.
Yes,
He
ma'am.
was breastfed within an hour and he was
Exclusively
on exclusively breastfeeding and sent home on
postnatal
exclusively breastfeeding. Good.
developmental history, no history of any developmental delay. All milestones were attained appropriately. He studies currently in 6th standard. He has good scholastic performance. He reads and writes English, Malayalam, and Hindi and performs simple arithmetics. Diet history, he was exclusively breastfed up to 6 months. Complementary feeds were started at 6 months with ragi and started family pot sharing by 9 months.
So before going to his present diet, can you tell me previous slide. Dunya, can you tell me what are the questions you should ask in a complementary feeding history based on the new IYCF indicators?
Was the baby initiated on breastfeeding within 1 hour after?
No. That is done. Complementary feeding. Regarding complementary feeding. What are the minimum questions? Previously, we were happy. Started with ragi, then slowly went to family pot feeding. But now, based on the new IYCF indicators, we should ask few more questions. Especially if it is a small baby, we should be asking in detail. What are they?
Was the complementary feeding started at 6 months?
Okay.
Was the minimum meal
minimum meal
frequency, minimum meal diversity,
and minimum acceptable diet.
Right.
So that we should be asking about the 6 attributes of complementary feeding also we should be asking. What is the minimum dietary diversity?
At least 5 out of the 7 food groups should be
5 out of 8.
5 out of 8 food groups.
That is essential component is breastfeeding. Continue breastfeeding till 2 years and
2 years
beyond. So if you are taking the 7 food groups, excluding breast milk, then it is 4. Otherwise 5. 5 food groups should be there. And all of us must be aware of what are the 5 food groups for the baby and minimum meal frequency also, no? And minimum acceptable diet. So that 2 days back we were discussing on that. So we have to ask these questions also. And early introduction of complementary feeding before 4 months is found to be one other risk factor for obesity. But that is not there in this child. So fuel excess in utero. And we know his lifestyle, his eating habits, everything we said so many years is an overeating is contributing to his obesity. But mother waited till 6 months. More than 4 months is one risk factor for future obesity. Next. Now we go to his diet.
This is his current diet, which was being taken during this summer vacation.
So he eats how many times?
Every 2 hourly he keeps eating while at home.
8
and
feeds
he predominantly
he is a 12. He's going to be a 12 adolescent boy, no? 12-year-old. He's eating at least 8 times, like a small baby. He's eating, and then the quantity. He's eating 6 to 8 idlis isn't it?
Including
Then 10
seconds,
a.m.
sir.
again 5 idli. So on the whole, he's taking 13 idlis. Huh? So much of rice, so much of curry, everything, plus tea, biscuit. And biscuit is one packet he's eating, not 1 or 2 pieces. So now I think that is the dictum. 7 chapatis he's eating. Look at the diet and see how much he's eating. 6 plus 4, 10 katoris of rice he's eating. So much he's eating. And here I want to ask you a few questions so by taking sambar, he's getting 5 grams of protein. So what is the protein source in sambar? If I take a whole egg, which is deficient in carbohydrate, full of fat and energy, I will get only 6 grams of protein. By taking sambar, how will I get 5 grams of protein? What is the source of?
Dal, potato.
Dal. How much dal do you put in a pot of sambar? 2 handful. Isn't it? Isn't it, Dr. Dali? 2
Madam.
handfuls.
Yes,
Yeah?
yes, madam. I was also planning to ask the same question. The
I
calorie
always
and
ask
protein.
this question. So you put sambar and say it is all for variety. Huh? He's getting some vegetables, some variety he's getting. Huh? Most of our undergraduates say by taking sambar, chutney, they will get 100 calories and 6 grams of protein. This I usually see from UG side. But just I'm telling you that, so some of these calculations, you will have to recalculate. Okay. On the whole, anyway, this is a very huge diet, like Bhiman's diet he's taking, I must say. Then go to next.
Elizabeth madam, one thing I want to say. I am Suresh madam.
Yes.
Madam, regarding that sambar and chutney, one of the books which UGs use says that chutney gives 100 grams chutney gives 444 calories.
Who will take 100 grams? They will,
that is the issue,
most
madam.
of the children will take, that is the whole coconut they are taking.
That is for dry desiccated coconut, I think.
Yeah.
That calorie content is for dry desiccated
So
coconut.
this is
and
all, they take only, most of the small children, we calculate like this, no? They take just for the sake of satisfying the mother, they take 1 or 2 spoons. And there are some people who take one whole tumbler of sambar and all, but children usually don't take. And the protein source, this you can say some vegetable curry, which has got multiple vegetables. So that is for variety. It will supply some micronutrients, fiber, etc. It's not as a protein or energy source. I think we teachers should be correcting that. Huh? Next, go to next. Go to next. So you will have to rework on this, but due to lack of time, I'm not going into that. Whatever it is, so you say that he is taking. Continue.
Excess calories. Expected calories according to ICMR recommendations are 2,220 according to his age, and he is getting 5,710 calories, and he is getting an excess of 3,490 calories. And his protein requirement according to ICMR recommendations is 26.2, and he's getting 196 grams of protein and excess of 169.8 grams.
So actually, when we are doing this dietary calculations, we should call the dietitian also, because we are busy. And one approximation only we can say either it is less or it is more. But the dietitian will have to sit with the child and show them what is the standard size. The dosha that you get in the Sharavana Bhavan is having so much of batter, no? Whereas what we make at home, the idli that we get in Sharavana Bhavan versus that we make in home is very different. And the spoons, the katori, everything, the dietitian will have to show. So this, if I hope you have a dietitian, no? Ask her to do this recalculation, and if you can share it with us, that would be interesting. Huh?
Madam, we don't have a dietitian in our hospital.
Okay. But medicine may be having. Huh? Other department may be having, because you are
only one in the MCH, I think.
Still, you can refer this child to and get a correct this thing. Okay. And here I want to say that so much of protein is excess. And when you calculate any child's diet, you find that there is a deficiency of energy, not this child, others. Because Dr. Suresh was also asking me that question. And sometimes the students say protein is excess, 10 gram excess. And when there is a 300 calorie gap, this 10 gram protein will be wasted for energy. And 1 gram of protein will give how much energy for the child?
4K.
So you may be projecting that this child is having 10 gram of protein excess, but that 10 gram will be just wasted for 40 calories. So you must say that it seems to be little more in numbers, but it is mostly an incomplete protein. From what sources? It is not a complete protein that we get. It is not a reference protein. So my point is that don't project that this child is having excess protein. Whenever there is a huge energy gap, this child is definitely having, and he is not spending also. This child is having so much. And you are supposed to comment on his micronutrients also. It is not only energy and protein. That PEM is gone, no? Protein, energy, malnutrition is gone. It is not protein and energy only. Micronutrient has a big thrust. So what is it? Iron-rich food he is getting? No, vitamin C?
It is deficient.
What is his vitamin D? So you must highlight that. That is one point. Many people say obesity is overnutrition. I always say it is malnutrition. He is having multiple deficiencies. If you check, he may be vitamin D deficient, iron deficient, zinc deficient, so much deficiency may be heard. So you must highlight that. In spite of this, so it is the correct malnutrition. Okay, go to next.
Immunization history.
He's immunized till?
He's immunized till 10 years of
10 years of age. Okay.
Family history. A 6-membered family including father, mother, 2 younger siblings and grandmother. There is history of obesity in mother following 3rd delivery as per her history, and current weight is 98 kg, and she had a surgery for lipoma on her back. History of dyslipidemia and hypertension in maternal and paternal grandmothers.
Is that enough? We have to say dyslipidemia and hypertension in maternal and paternal grandparents will be usually there, but is there a genetic dyslipidemia? That is early onset. What age they developed all these things? That is the most important thing. Anyone else is having obesity in the family? That is also very interesting.
No, only mother is having obesity. His father and other 2 siblings are of normal weight only. Other 2 siblings are currently 25 and 30 kg nearly weight.
Okay, continue.
No family history of any children with abnormal facies or developmental delay. Socioeconomic.
You could have drawn a pedigree. Okay. Always draw a pedigree. Then good, continue.
Father, he's educated up to 7th standard. He runs a wholesale chicken and fish store. And mother is a MLT graduate. She's a homemaker. And 6-membered family on concrete house. This is 2-story with a sanitary well. Kupuswami scale, he belongs to upper middle class.
So they are having so much of chicken and fish at home, no?
Yes.
Most of the children who are obese now they say we run a shop. So he always comes and takes the Oreo biscuit and everything and goes. So pastry shops they are running. And some families, the mothers are making so much of cake. They are selling, but the children also take a lot of that. Yes, lifestyle in our part has changed. Continue.
On general examination, he was alert and active. No pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Pulse rate was 98 per minute, regular rhythm, normal volume. All other peripheral pulses were bilaterally felt equal. Respiratory rate was 24 per minute, abdominothoracic. Blood pressure was 120/70 and it is less than 90th centile. Saturation was 97% in room air. Temperature was 98.6.
So it is good that you brought the centile of the blood pressure also. So he is not above 90th percentile.
Okay. He's not having hypertension.
Also pre-hypertension or
No, no prehypertension also, less than 90th centile.
okay. How many, which all vital signs you have left out? Go back. You have 4 vital signs. Now they say there are 7.
GRB,
Temperature, GRBS, and saturation you have got. CFT, capillary filling time. So the importance of capillary filling time is that it can detect the compensated shock, no? Compensated stage of the shock. Decompensated only, otherwise BP. If you go for the BP, we are losing the window of opportunity. Okay, next, continue. Temperature is there.
Yes, madam.
Continue.
This is BP centiles, and this is the current photo of this boy, which was taken when he came for exam, when he came for OP.
What is very striking? Yeah, what is striking? Gynecomastia. Actually, nowadays, some people call it lipogynecomastia. So much of fat is there. So the more than the hormonal imbalance, it may be fat which is coming in. Lipogynecomastia. And the picture is not very clear. Otherwise, looking from the front, whether acanthosis is seen or not. And sometimes they may have looking very, they may say that the genitalia is also not very rudimentary because it may be all embedded in the fat. These are the things. And how he is standing, his posture, he's having?
Septum.
Genu? So much genu valgus, no? So much genu valgus he is standing with. And is he having a flat foot? Did you check? What is P-Gals? P-Gals is a station for DNB.
Pediatric
gait, arm, limbs, and spine. Okay. So we have to, it is usually done with musculoskeletal system, but sometimes examiners may ask you, what is his gait? Is he having flat foot? Why he is having, what abnormal posture he is having? Okay. Continue.
Head to foot examination. Head size normal and head is normal in size and shape. Hair normal, no facial dysmorphism. Eyes, ears, and nose were normal, no xanthelasma. All cavity, no dental caries. Tonsils were normal. Posterior pharyngeal wall was normal. Tongue was normal. There was acanthosis nigricans over the neck, which was of grade 4. That is, grade 4 means it can be seen from the front also. It is extending anterior.
Grade 1?
Grade 1 is can be noticed only on close observation.
Close observation you may feel. Second? It is
limited to the base
back
of the skull and
it
not
is well
extending
seen on the back. Then 3.
Grade 3 means it is extending laterally, but not extending anterior.
Not seen from front.
Not seen from front.
Then 4 is seen from the front. Axilla also same. Close observation in the
grade 1
apex of the axilla. Then it slightly very visible. Then
central portion.
Sides. And when the arm is adducted,
it was not visible, so it belongs to grade 3. If it is visible from front and back, even with the arms by the side.
What does it mean? What does it mean to you?
It's a sign of insulin resistance.
Insulin resistance. Okay. So mother may say it is because of he doesn't take a good bath, or it is because he has got a black chariot on his neck, something and all they will say. It is because allergy to the thread and all. But we must tell them that this is a sign of obesity and a step ahead, which is insulin resistance.
Then chest, bilateral gynecomastia was present. Abdomen, nose, striae. There was hyperpigmentation with exploration over the medial aspect of both thighs, which was due to rubbing against each other, both thighs being rubbing against each other. And this is the picture of axillary acanthosis nigricans. It is almost entirely occupying the axilla. And this is the acanthosis nigricans over his
Suppose he has itching also. What will that mean? This description with itching also. Suppose he has
gallstones.
no, only at the point of that hyperpigmentation. It is because he's having rubbing. You said if there is itching, you must think
Fungal
of
infection. Secondary to
mucocutaneous candidiasis. Candidiasis, you must think. Okay, next.
And this is the picture of his genitalia. There was no micropenis and SMR stage, Tanner stage was 2. There were multiple heat lesions suggestive of insect bite reactions or the extremities. Hands and feet were small, which were normal, not small. External genitalia was of male type. Testis bilaterally descended. Stretched penile length was 8 centimeters. There was no apparent micropenis. Testicular volume was 6 ml and SMR was Tanner stage 2. Fundus, there was no papilledema.
So why did you look at the fundus in this child?
To rule out pseudotumor cerebri, which can occur associated with obesity.
Very good. Pseudotumor cerebri. Anything else?
Then
Rahul and Chinnu?
retinitis.
Anything in the history? Which you hurriedly said. He has headache. He has headache. He has headache. And usually headache may be tension headache, migraine, but nothing was suggestive of a migraine, isn't it? So that headache is maybe significant. So it is good that you looked at the fundus. Pseudotumor cerebri because of this problem, or he has a complaint also. And can anything in the head lead to obesity?
Hypothalamic tumors.
Yeah.
Hypothalamic obesity.
Yeah, hypothalamic or pituitary obesity may be there, isn't it? So it's good that you looked at the fundus. And papilledema will be seen in infratendorial or supratendorial at the early stage, which will produce papilledema, which is by far more common in children. Tumors, infratendorial or supratendorial?
Infratendorial.
Infratendorial, and that will lead to blocking of the CSF, isn't it? Aqueductal stenosis or blocking is more common. Whereas this, tell me any tumor of the hypothalamus or pituitary. You said
Craniopharyngioma.
Hematomas, somebody has Galaxy M31, no name is there. Hematomas. Okay. And craniopharyngeal, these are infratendorial or supratendorial?
Craniopharyngioma, supratendorial.
Supratendorial. So papilledema may be a very late sign. Okay. And some of these may be slow growing. We have seen that in precocious puberty, after many years, MRI showed a tumor. But as when the child was having the precocious puberty, even the imaging did not show the tumor. So such stories are there in history. But it's good that you said about papilledema. One is because of the pseudotumor cerebri. Second, he has a headache. And his obesity may be because of some CNS problem also. So 3 answers are there. Why you looked at the fundus. Okay, continue. Good.
Then coming to the anthropometry, his weight is 96.6 kg and expected is 39 kg. And this is 147.6% in excess of the expected weight.
So what is overweight? What percentage is overweight? Before we had all these Sendai charts and all, we used to say more than 120%.
More than 120% above.
120%. So he is having almost 150%, no?
Yes.
147.6% overweight is there. And it is above the 97%.
And his height was 162 centimeters and expected is 149 centimeters and it lies between 90th and 97th centile. And BMI was 36.4, which corresponds to severe obesity, more than 35.
We call it Morbid obesity.
Morbid obesity.
Not severe. We call it morbid obesity. Okay. And you have the charts. You will come to the charts, no?
Yes, ma'am. Next coming slides will be showing charts. Mid-arm circumference was 37 centimeter. Head circumference 53 centimeter, which was normal. Then waist hip ratio was 1.08, which is increased. The normal value should be less than 0.9. Then skin fold thickness was tricep skin fold thickness was 45 millimeters, which is
What
also
calipers you used?
Harpendance calipers.
Okay. So it was 4 times, almost 4 to 5 times more. More than that. So out of this, all the measurements, which is the most important measurement that you will rate, which is the most important measurement that you have taken?
BMI, waist hip ratio.
Rahul, Chinnu, anyone else? Any answers in the chat box?
Waist hip ratio. Waist hip ratio.
Skin fold thickness.
In any case of obesity, what is the measurement that is going to help you? The height.
Yeah.
The height. The answer should be the height. Because, we rate it into pathological or secondary or exogenous based on the height, first of all. And that is needed for us to calculate the BMI. And so height is the most important measurement that you should be taking in a child with obesity. They usually come with the weight, but height is the most important measurement. Okay, go to next.
This is the IAP chart depicting his height and weight. And height can be seen. This is more than 90. Weight is seen to be more than 97 centimeters. Height seems to be like between 90th and 97 centimeters.
So here, what is your comment on that? The weight is much more than the height. He is on the taller side.
Yes.
Okay. But his weight is much more than his height. That is the point. Then what we should do? What other measurement you should do? Or what other plotting you should do?
MPH should be calculated.
Yeah, you have done it.
Yes,
Go to next chart. So rate him according to his mid-parentile height centile. Okay. So this is the pediatrician friendly chart. And what is the expected for? You should have plotted it at 18 years. Now you have plotted him at 12 years. You could have plotted this at 18. So what is it? We can't see. I can't see. I can't read also that. So what is the mid-parental height? You should plot it at 18 years and say, what is the measurement?
176.5 is his MPH.
176.5
0.5.
is the mid-parental height. What is the height of the father and the mother?
Father 176, mother 164.
So Dr. Rahul can calculate because we can't read. Dr. Rahul, please calculate and tell us what is it. So whatever you got, will you plot it there on 18 and tell us what percentile he should reach? What is his potential to reach?
Plus or minus 8. 176.5 is mid-parental height. And its height at 18 years, its height should lie between 176.5 plus or minus 8.5 centimeters.
So where it should come? 97th percentile, that is my question. 95th percentile, where is it? Is he taller than that, or is he only up to his mid-parental height? Because his parents are tall. Centile, mid-parental
Between 50th and 70th.
centile. So at 18 years, you plot 76.
Between 55 and 75.
Because you are this thing, I can't see, I can't read the numbers.
Madam,
That is why I'm asking. So
the
anyway,
NPH is, madam, 176 plus.
that I understand, but I am asking
is
what is the
coming
centile? Mid-parental centile is the most important thing, no? The child's
50th to
potential is,
75th, madam.
it is
50th and 75th.
so that is your, so now I say that it's there, it seems to be a disparity between the weight and the height. The weight is much more than the height, but then is his height only up to his mid-parental centile, or is it more than that? What is the answer? It is more than that, isn't it? Yes. And obesity, much above the obesity line also he is coming. You go to the previous slide. So always mid-parental height should be plotted. It should also be plotted, and then comparison should be made. 18 years you plot it and say this is the centile of that and rate the child. Okay, go to next. So it is all, it is like above the paper, no? It is so much outside. So morbid obesity. Okay, continue.
This is his base circumference.
That is also
Or could not be plotted on this. It was more than 95th centile.
So it is above 95th centile. So this is from Vaman Kadilkar.
Yes, ma'am.
So what is the centile that he has said is a risk factor for metabolic syndrome? Which centile is a risk factor for metabolic syndrome according to that chart, Dr. Vaman Kadilkar's chart? And what is the centile above which you diagnose? It is a diagnostic criteria for metabolic syndrome. Above 90th percentile is a diagnostic criteria for metabolic syndrome. Above 90 percentile, above 70th percentile is risk factor. Yeah, Ria Matthew is answering 70th to 90th percentile. So 70th percentile is taken as the risk factor, and 90 above is taken as diagnostic criteria. So 70% for him will be only 85 centimeters. So he's much ahead of that. Okay, continue.
Sister examination of GIT, upper GIT, oral cavity, no dental caries.
What finding did you expect and what finding you got?
If he's taking too much of sugary food, he can get dental caries.
Good.
Then tonsils and pharyngeal also I examined because to rule out obstructive sleep apnea.
Very good.
Increased fat in the neck can cause compression of the structures and cause obstructive sleep apnea.
Palpation and
exam, I expected to find a hepatomegaly.
What is this?
Due to fatty liver.
Is he having fatty liver?
Yes, madam. He's having fatty liver, and liver was palpable 3.5 centimeters below the right costal margin in the mid-clavicular line, which was soft in consistency, smooth surface and non-tender, and liver span was 14 centimeters.
So he is having
hepatomegaly.
Is it a smooth and round surface, round?
Yes, it was smooth
surface, round border. That is suggestive of fatty liver. If it is other causes, it may be firm, sharp borders, etc. Okay. Go to next. CVS, what did you expect? What did you get?
Hypertension can occur as a comorbidity in obesity, but he was of normal blood pressure.
Anything else?
Then if there was pseudotumor cerebri as an associated complication of this obesity, he could have got tachycardia.
Very good.
But these both were not present.
That is all normal. Next, then some dietary deficiencies also. Any dietary deficiencies can cause cardiovascular findings.
Selenium.
Selenium, cardiomyopathy. Then thiamine.
Beriberi, vitamin.
Again,
Vitamin.
cardiac failure. Then now recently thiamine produces in breastfed babies. Thiamine is found to produce pulmonary hypertension. Thiamine responsive pulmonary hypertension. Vitamin D deficiency. So many deficiencies can affect your heart. So you have to look at that because his diet is not a balanced diet. Next. Go to next. Respiratory system.
Respiratory system was normal.
So you look
normal. There can occur
upper airway,
asthma,
upper airway
comorbidities such as asthma and obstructive sleep apnea due to upper airway obstruction can occur. System examination was normal.
Nervous system. What did you expect? What did you find?
Any neurological abnormality can
If
occur.
there is pseudotumor cerebri,
Raised ICD, papilledema can occur. Visual disturbances. Then migraine.
No, in the CNS examination, what do you expect? Some tumors are there or some raised pressure is there.
Cranial nerve palsies can occur if there is raised ICD.
Cranial nerve, especially fourth nerve. Non-specific. Lateral rectus palsy you can look for. Then brisk reflexes and upgoing plantar. Isn't it?
Yes.
Suppose there is features of ICP are there. So it is not there. Then what can happen to skull and spine? So much of abnormalities can be there. What are they?
There can be hip pain, back pain, orthopedic complications can occur.
Complications.
Like slipped capital femoral epiphysis. Then tibial, varus deformity of tibia.
Varus
Then
deformity,
avascular
which is
necrosis.
already having. Then sometimes
Avascular necrosis.
they may be stooping because of the gynecomastia and all, or because he is very tall, he may be stooping. So spine abnormalities also can be there. And adolescents have what abnormality?
Slipped capital femoral epiphysis.
Spine.
Physiological
lordosis. Here, instead of lordosis, they may go stooping also because of the gynecomastia and tall stature than others. Okay. Next.
Summary. 11 3/4-year-old boy, firstborn of non-consanguineous marriage with a birth weight of 4.250 kg, uneventful postnatal period with no significant past history.
Instead of telling that, you must say that he was a large birth weight baby. You pick up the points that you got.
LGA baby.
One is mother is having
obesity.
He was born to a mother who has obesity. Then he had fuel excess in utero, isn't it? Gain, she seemed to have a gain more than her. Her BMI is more and the weight gain was more than expected or recommended for her. So fuel excess evidence is there. So he was born as a large birth weight baby. Then what?
Then mother has obesity and on examination.
No. You are leaving all the factors there. Post-COVID, he had
increased
more screen time.
Calorie intake, more screen time, reduced physical.
His lifestyle changed. So much of lifestyle changes in the last 3 years. Last 3 years only, he's having all these problems, no?
Yes.
And his eating behavior has changed. He's eating so much more. Eating almost 150% of energy, more than what is expected for him. He's not taking a balanced diet. He's overeating. And then in the history, what should have come?
Any associated complications?
Less, all the S I said. Huh? Junks. So what are junks?
J stands for high calorie.
Okay,
Junk
we'll
foods.
come to that. We'll come to that later because we have a slide on that. You should have highlighted. He's taking so much of high in salt, high in fat, high in sugar. He's nutritionally inappropriate. Ultra processed food. He's taking
Sugar,
colas,
extra added sugar.
and beverages. So why he's having the obesity? You have the points that is what you should highlight in the summary. So with an altered eating behavior and so sedentary lifestyle changes, and now he's coming with
Increased weight gain. Increased appetite.
So his anthropometry shows
BMI, which is more than corresponding to morbid obesity.
Highlight should be that 146% excess of weight, but he is tall, even taller than his mid-parental height. He is taller than his mid-parental height percentile. And he's having so much of BMI, so morbid obesity is having. Then he's having features of
insulin resistance,
hypogynecomastia, and
acanthosis nigricans,
advanced grading of
acanthosis
nigricans, and so much of central obesity as evidenced by his
waist hip ratio, which is 1.08, and increased skin fold
circumference. Nowadays, they say that in a school, adolescent child and all, waist hip is difficult. And some children may put a case against you, FOXO case also, because we are not supposed to touch them like that, no? So they say that waist circumference is all what is needed. And waist circumference, ask the child to put the tape just above his iliac crest. Previously, we had to find the midway between the rib cage and the iliac crest. Yeah. Now they say no need. Just so ask the child to feel his iliac crest and put the tape above that, and then you read it. Don't touch the child. Most of the time, the older children can do it for you. And the skin fold thickness is 4.5 times more than the expected. Okay, continue. With what? Then what? Then what?
Sister examination.
This is summary is over. This is incomplete. You have more findings. What are they?
With hepatomegaly.
Evidence of fatty liver is there. Hepatomegaly, fatty liver is there. What else did you get? Orthopedic changes, no? You said so much of valgus deformity will come. Why you are ignoring all that? Put everything, what you got. Weight for age, height for age, weight, BMI, all the measurements, and plus whatever you have got. So now he needs an orthopedic evaluation, isn't it? We can't send him like that. He may get it worse because his body weight is so much and the deformity will increase. So now itself he'll have to do that. Then continue. So put in all that. And now what is your diagnosis? Okay, come to your diagnosis.
This could be probably a case of constitutional obesity because he has increased food intake and his height is not affected.
What is a better term for that?
Exogenous obesity.
So that is it. Exogenous
obesity.
What percentage of obesity is exogenous obesity? And what percentage is non-exogenous?
Majority of the obesity are exogenous, more than 90%.
This is a UG competency, actually. UG serves now competency, no? What is the percentage of? It is, so most of the books say 95 to 98%. Two has answered 98%. So, yes, most of the books say 98% will be exogenous obesity and 2% only will be the rest. And some books say 95 to 98%. Majority means it is almost nearing that. Very few are exceptions to the rule. So why do you say it is exogenous obesity?
There is history of increased food intake with increased calorie intake is there, along with increased appetite. And his age, this pivotal age is
Lifestyle,
only associated with
his eating practices, his lifestyle. One. Then Ria has answered height is
not affected.
That is why I asked what is the most important measurement in a obesity child. 98% will be tall. That means they are, most of them are exogenous obesity. If you get a short child, shorter than his mid-parental height, percentile, that case you have to work up for the rest of the obesity. The height is the most important measurement. Then, okay, exogenous obesity, and someone, Ria Matthew is writing normal intelligence. Why? How that is important? Normal development. You have put it normal development. Good scholastic performance. Why that is important?
In syndromic obesities?
Yeah. They will have poor scholastic intellectual disability, behavioral problems, poor scholastic performances will be there. Then, what are the complications you have missed out? You have said you must write grade 4 acanthosis nigricans. That is also should come in the diagnosis, which is suggestive of insulin resistance. Then fatty liver is left out. Orthopedic complications are left out. Don't leave out. Have a comprehensive, holistic approach to this child. So 95 to 98% of the time, this child also may be exogenous obesity because he is having all the history is suggestive, the examination findings are suggestive. Then you have any DD? You have 2 DD. Why do you consider this DD?
Madam, there is hyperphagia can be due to, in these cases also hyperphagia is there. Hyperphagia seems to be disproportionate. He keeps eating every 2 hours.
So much overeating.
And he was a LGA baby.
And what else? He will have so much of fighting, aggressive behavior when food is denied. That is there. That is something which we have to. And he has a headache. So he has a headache, unexplained headache. Then he has aggressive behavior when food is denied. And in which condition do you say you must lock your refrigerator and go? Otherwise, the child will finish all the food in the refrigerator. Which condition? Typically, the parents say, I have to lock the refrigerator and go. So much overeating. Anybody? It is Prader-Willi. Prader-Willi. Hafsa has answered. Good. Hafsa has answered Prader-Willi. You will have to lock all the food and go. Otherwise, the child will finish. So much will be there. So, what is this hypothalamic obesity? Why did you put it as a, what are the points in, points against? So, you think that everything is fitting into exogenous obesity, overeating, sedentary lifestyle with few complications. But 1 point you may think against, 1 or 2 points are against. One is the hyperphagia and the aggression when food is denied. And second is the headache, the unexplained headache. So, which should come as the second diagnosis?
Hypothalamic obesity.
Yeah, hypothalamic. Some central cause, hypothalamic or pituitary cause, we have to rule out. That should come. And will they be short or tall? Hypothalamic obesity?
Short.
What will they produce? But if it is a overproducing tumor, what will they produce? Hypothalamus, pituitary, what will it produce?
Gonadotrophins.
Growth hormone. And if growth hormone is more,
tall stature can occur.
what will happen? What is the mediator of growth hormone? Growth hormone acts through
Insulin-like growth factor,
IGF-1. So in some of these conditions, IGF-1 may be taught. If you look up the literature, IGF-1 may be high. So hypothalamic obesity, if it is a destructive tumor, it can be a overproducing tumor or a destructive tumor. If it is a destructive tumor, the height and all may be affected. Otherwise, they can produce hormone secreting tumors also. What is this monogenic obesity?
genetic syndromes associated with obesity. Leptin, due to leptin deficiency or leptin receptor deficiency or leptin resistance. Then other gene mutations.
What is the leptin level in an obese child normally?
It will be decreased as it is the satiety hormone.
So in exogenous obesity, what produces leptin? Where is leptin produced?
Adipose tissues. So
what are the two types of adipose tissue?
White adipose tissue produces.
And white adipose tissue produces. So brown adipose tissue is the good one. Browning of fat is what we aim when we are losing weight, no? Some diets will brown your fat, they say. That is good. Brown fat is good. The white adipose tissue is bad, but white adipose tissue is also an endocrine organ. Now we know that it produces leptin. So leptin deficiency is seen in the monogenic obesity. Otherwise, no, when you have a lot of adiposity, before the feedback inhibition comes, it may be producing more. It can be variable. Otherwise, in monogenic obesity, leptin deficiency will be there. Sometimes leptin is more, but receptor deficiency is there. And other monogenic obesity, it is a wide basket diagnosis.
Melanocortin-4 receptors.
Other hormones which are important in energy homeostasis plus
POM.
Other syndromes. You know any other syndromes where there is obesity?
Prader-Willi syndrome, Ostrom syndrome, Cohen syndrome,
Weaver syndrome. So many syndromes. So in syndromic obesity, also some of these, the Beckwith, Widman, Ria Cherian is answering. Okay, so that is very interesting. No, it is a huge group. But I think you must prioritize hypothalamic obesity above this. Next. What are the syndromes of hypothalamic obesity? Central obesity, gigantism.
Soto syndrome. Overgrowth
syndrome. And what is in adults, it is called gigantism in children. Gigantism in children and acromegaly in adults. Because Rose is answering acromegaly. Good. So acromegaly is after the bone growth is completed. Otherwise, you said hypothalamic obesity will be short. But the cerebral gigantism is tall, no? So it is not one diagnosis. Some tumors may be producing the stimulating hormones also. Okay, so hypothalamic obesity should come above the monogenic obesity. If he was mentally subnormal, poor in scholastic performance, shorter than his mid-parental height, then we could have considered the chromosomal anomalies or monogenic obesity. Can it be looking at him, somebody may diagnose Cushing syndrome for him. What do you think?
There was no hypertension.
Cushing syndrome?
Striae was not there. No hirsutism.
Mooning of face, buffalo hump. Then
moon face is buffalo hump, striae, hypertension and all was not there.
Short stature, no?
Short stature.
Short stature. Okay. Go to next.
Then this is slide on metabolic syndrome. The criteria for metabolic.
So you should have put it like this. I want to hepatomegaly is there. So I want to investigate him for hepatomegaly can be fatty liver, but steatosis
And steatohepatitis.
versus steatohepatitis. So whether he is having steatohepatitis, I want to investigate. So you must put with these complications. Most probably insulin resistance I am seeing, but I want to investigate with probably metabolic syndrome, which I want to test. Then I want to test whether he is having only steatosis versus steatohepatitis. Then what are his orthopedic complications? Any eye complications can have? CNS complications, eye complications. Okay, next. So in metabolic syndrome, so base circumference more than 90th percentile. Is he having that?
Yes, he's having that.
So whatever he is having, you have highlighted. So you read what is metabolic syndrome.
It is the criteria for metabolic syndrome is waist circumference more than 90th percentile plus 2 or more of the following criteria should be present. That is glucose, fasting blood glucose should be more than 100 milligram per deciliter, and
So
blood pressure.
This should form your how will you investigate this child? I want to look for this. Okay, blood pressure he is not having.
His fasting blood glucose was also normal, which will be coming in the later slides. And triglycerides, he's fitting this criteria. Fasting triglyceride should be more than or equal to 150. Then HDL should be less than 40 milligram per deciliter. Child should be on treatment for hyperlipidemia. This is a criteria. This is a criteria in children aged 10 to 16 years.
Okay. So, and for risk of metabolic syndrome is waist circumference more than 90. What is adiposity rebound? What is adiposity rebound? Whenever you are tracking BMI, we always say adiposity rebound. What is that? Anybody?
Adiposity rebound. Madam, in infancy, the adipose tissue there is increased adipose tissue, and it drops it gradually decreases until 5.5 years. And it gradually decreases, and the adipose tissue increases towards the adulthood. And the dip is seen.
Good.
And from 5.5 years, it is gradually increasing. And that
BMI,
is the adipose rebound.
BMI is 13 at birth. It increases to 17, shoots to 17 by 1 year. Then by 5 to 6 years, 5.5 years, as you said, it has to dip to 15. And then slowly the adiposity will have to come back. By 5 to 6 years, an added should come. But now most of the children are not having this decline. They are quickly from 17, they are going to 30 and 20 and 25 and 30. So earlier the dip or no dip in the BMI tracking. So in a family where the mother is obese, there is one child who is obese, we can do a tracking of BMI. That itself is an intervention. Okay. And later the dip, more of malnutrition. Earlier the dip and no dip means they will end up as obese adults. Okay, next. So he is still not having metabolic syndrome. He is only having risk for metabolic syndrome. Go to next.
His investigations were as follows. His FBS was 88 and it seems to be normal. Total cholesterol was elevated. It is 239. Triglycerides were also elevated, 247. It was 247. And HDL was normal, 45. And LDL cholesterol was 156. VLDL
should be little more higher, no? Okay. Vitamin D?
Vitamin D, there is insufficient, 16 only.
What unit? Without unit, how can we interpret? Units are different, no? In different labs. So this is nanogram per?
Nanogram per.
What is expected?
More than 20. 12 to 20 is insufficiency and less than 12 is deficiency.
Some people even put it 30. Okay, so it is on the lower side. Okay, agreed. Next.
Then CBC.
So we were telling that he can have multiple deficiencies and markers of inflammation you want to look for. What is acanthosis nigricans? It is proliferation of acanthocytes.
Due to IGF, insulin-like growth factors.
That is an inflammation actually. It is an inflammation. So you must look for other markers of inflammation. Hemoglobin is normal. Okay. Total count?
12,020.
Normal limit.
Rest of the parameters were normal. Free T4 and TSH was also normal.
What do you expect in an obese child, TSH?
TSH can be
Yeah, it is
increased.
usually on the higher side, but don't start telling that Sutto is answering high. It may be on the higher side, but no need to start thyroxine. If you start thyroxine, what will happen? His appetite will increase, his metabolism will increase. He will again put on more weight. You have to do the, what you will have to do? Weight reduction and retest. Okay. Next.
LFT, liver function test. TSB and TSB was 0.6, direct fraction was 0.18, total protein was 6.1, albumin was 3.8, SGOT was 42, SGPT was 46, which is raised.
What is the cutoff?
35.
No, the pediatric hepatologists are now suggesting that 22 for girls and 25 for boys. Actually, when you take 50 as the normal, it is actually double the normal. So have a baseline LFT. This is a sign of steatosis going to steatohepatitis. Transaminitis is there. Suppose OT was only increased, then you can say it may be because of some intercurrent viral infection. Dengue also will have, influenza also will have, but PT is also increased. So he is having features of steatohepatitis. And steatosis and transaminitis. The new cutoffs are 22 and 25. Pediatric Hepatology Association, their cutoffs are 22 and 25. And USG says mild hepatomegaly with fatty liver. How can you quantify fat? Any test?
DEXA.
Any other scan? DEXA.
Then ultrasound, high resolution ultrasound, MRI scan.
Fibroelastic scans can quantify. Next, go to next. So
then this is a model.
Okay, so I have asked her to put a model diet, and so he was eating 8 times. Now she says he can eat 1, 2, 3, 5 times he can eat with the intermittent fasting of 12 hours, no, 8 p.m. to 8 a.m. Intermittent fasting, 12 hours of fasting. So here also I want to ask you, soya curry, how will soya curry give 40 grams of protein? 100 grams of soya will give 43 grams of protein. Is he going to take 100 grams of soya? So when you make, it should be realistic. And so when you make a diet, you have to tell them that you have to go for a 3 meal, and if you really want, you can take some drinks like little salted lime juice or something, which is not going to give you any energy. Okay, that we should tell. And here you have, so you have to avoid all the junks. And how can you reduce the glycemic load? By reducing the carb. Most of the diet you have given is carb based, cereals, isn't it?
Yes.
So you must say that he will have to change his diet to a low carb diet and avoid all the junks. Junks list you can give. Tell him to go for a low carb diet, and then, and if he is allowed to eat rice, he will definitely eat more rice. Mother will cook in large quantity, serve in large quantity, eat in large quantity. So he'll have to find alternatives. Now millets are whole grains, whole millets are alternatives which we'll have to teach him. And in most of the studies have shown that this is like 70% of the energy will be coming from carb. So you have to tell him that he has to go for 40 to 50% of the first thing you have to teach them is avoid junks. No frequent eating. Have a long duration of intermittent fasting, at least in the night, if possible. 12 hours or 14 hours of fasting including the night. And the third thing is that cut your carb to less than 40 or 50%. And IAP is writing millets have low glycemic index and low glycemic load. So that is the change that we'll have to make. Cut the carb to 40%. Increase the protein to 20%. So it will be then the rest of the fat. Now we know that it is not fat-driven obesity. It is now carb-driven or sugar-driven obesity that we are facing. So that sort of thing should come. And to decrease the glycemic load and glycemic load and glycemic index are different. So glycemic index into how much sugar or carb is there. That is the glycemic load. Okay. Glycemic index is low in one item. But if I consume it in large quantity, I'll get a lot of glycemic load. So learn what is glycemic load versus glycemic index. And then if you take vegetables and fruits prior to your cereal or carb, the glycemic load will be much less because of the fiber and the entangling. It will be slowly only absorbed. If you take your rice first and last the vegetables, your glycemic load will be more. So what you have to tell them is that he should take salads, cut vegetables, and he has to learn the traffic signal type of diet. What are the items he can take? He cannot go on this diet, this family diet, and he will demand more, he will eat more. This is not going to work. You will have to change. The whole family will have to change to a new diet plan. Vegetables and low glycemic fruits, they will have to use first. That should be eaten first, then only serve the main menu, like chapati or whole grain or whatever it is. Then only it will work. And increase is exercise. 1 hour of exercise. 1 hour of exercise, 0 junks, 8 hours of sleep. 108. That should be taught to the family. And when there is 1 kg increase in weight, motivation to do exercise will come down 10%. So go and do cycling. He will go and sit there and come back. We will have to go with him. The family will have to find ways of making him active. Okay, next. So cutting carbs should come. And this we already discussed. There are different positions of doing the waist circumference. The best is just put the tape just above your iliac crest. Ask the child to put it just above the iliac crest. And then you crisscross and then read. That is all what it can do. Next, go to next. So we have some teaching slides here. Go on pressing. So health consequences of obesity. When I was preparing a talk, I tried to make, previous. Press back. Press back. So when I was, go to the next slide. Press once more. Stop. So when I was making this, what are the consequences of obesity, I was trying to put it in alphabetical order. And every alphabetic order, every alphabet, I could get a complication. And next picture, this all you can read up. And when you lose fat or when you lose the obesity, every organ, head to foot, is going to improve. Next. And the junks guideline, everybody should learn. High in fat, high in salt, high in sugar is junk food, which was accepted by the Delhi High Court also in a case. Ultra processed food, that is NOVA classification 4. 1, 2, and all, maybe keep it there. Okay, maybe okay. And nutritionally inappropriate will be the caffeine, chocolates, creatinine containing sports drinks, etc. in the growing child. Nutritionally inappropriate. Caffeinated, colored, carbonated beverages and short and sugar sweetened beverages. The junks guideline says that below 2 years, no fruit juice, only fruit. And after that, 100 ml of fruit juice. And fruit juice is different from fruit drink. Fruit juice should be 95% fruit. But we are taking 5 to 10% fruit and rest is sugar. 6 teaspoons of sugar may be added. So read the lassi which you enjoy. How many teaspoons of sugar is there? How many teaspoons of sugar is there in the fruity that you enjoy? They are all fruit drinks, not fruit juice. And the nectar that you buy, Tropicana nectar, will be 65% fruit. But it is still not a fruit juice. It is a fruit, something between the fruit juice and the fruit drink. Next. And so, ultra processed NOVA classification 4. Just have learned about this. Next. So the items are also here. The Oreo biscuit, the cornflakes, the Coca-Cola, whatever the packets are there. In packet food, whatever you get is ultra processed. So it is NOVA classification 4. Next. The traffic signal type. That is the green diet. Low energy, high fiber, low fat, nutrient dense. And the red will be high in calories, high in sugar, high in fat. But this FSSI, I wanted to bring it in, but they could not because there is a confusion. Some people say green dot means it is vegetarian. Red dot means it is non-vegetarian. So that confusion has not been sorted out. And when we wrote the junks guideline, we gave the recommendation that in schools and 150 meters around, junks should be banned. But when the law came, it came as 50 meters. The industry was stronger than we academicians. That is the story. Okay. Next. And this is another thing. Make the child to read the food labels. Here it is said that there is 250 calories and fat 110. That means 50% of the energy is coming from fat. So we don't want a product like that. And sometimes trans fat, it may be written there. And sodium, 20% of your RDA. Anything which is more than 20% is high. And 8 to 20% may be moderate. Less than 8% or 5% is only less. So ask them to learn to read the food labels. This will help the child. Next. This is again the traffic signal. We'll skip this. Everybody knows that. Next. Do we have any slides? So in this child, even though we are not qualifying him as a metabolic syndrome because he has only triglyceride high, no, plus the but in view of his neck acanthosis grade 4, I would suggest that please do the HOMA-IR. How do we do HOMA-IR? Homeostatic model assessment for insulin resistance. Get his fasting glucose, his fasting insulin. If the glucose is in milligram, divide by 405. And if the value is more than 2, he is having insulin resistance. So that is going to help the child. Don't wait till and do an HbA1c. Don't say that he has no glucose intolerance, impaired glucose tolerance, just because what is normal? His FBS is normal. So we have to do this in this child. And if there is insulin resistance, how can you help him? Cutting down carb and all we can teach, but what can you do? Next slide. There are 2 drugs which are approved. You can start that. If you prove that he has insulin resistance, you can start him on metformin. And orlistat also is approved, but sometimes oil leakage may come. So many of us may not start that. But if he has 0.2, we can start him on that is one. Rose, mute yourself.
Manu blocky.
Mute Rose. Go to next slide. So homo IR we'll have to do. And then this all we discussed, no leptin deficiency. Don't skip. Go back. Go back. 2 slides back. Now we'll finish. HbA1c should be less than 5.7. One question Dr. Leta is asking. HbA1c should be less than 5.7. No, before this there is a slide. Previous slide, which you skipped. So next. This one. So not this one, the previous one. Yeah. So just the names of the monogenic obesities, and then some of the overgrowth syndromes you will have to think of. And the overgrowth syndromes will start early, and they can have one sign of overgrowth is their visceromegaly they will have. So I may be thinking he's having fatty liver, but it may be an overgrowth syndrome with a large liver. So that is why I brought this one. The Soto syndrome is the cerebral gigantism and all. They are all overgrowth syndromes. Next. So endocrine causes of tall, must know what are the conditions of tall stature, pituitary tumors, precocious puberty, and syndromes associated with tall stature and obesity. Klinefelter syndrome. So that is one DD which we should consider. Okay, Sotos, Weavers are there. And tall stature who are lean, maybe Fragile X, homocystinuria, etc. So learn this, that is tall stature. Sometimes there are conditions where there can be obesity also. Next. And this is very interesting. The annual height velocity of 25 centimeters in first year, then it becomes 12.5, rule of 6 we say, rule of 2, rule of half. So 12.5 in the second year, then 6.25. So somewhere around 5.5 to 6. Then girls attain height velocity of why left hand? That is, the answer is that X-ray for bone age should be, because precocious puberty is 1 DD. not in this child, in a case with obesity, the non-dominating hand. Then IGF, I would say that get an IGF 1 of this child. If it is too high, maybe some hypothalamic cause also can be thought of. And if they can afford, or you can give it free, an MRI of the brain also, because he's having, it is not of early onset. No, 3 years only all this started, whether he's having any slow growing tumors or anything. So that is my suggestion. Homo IR you have to do, and then start him on metformin if it is increased. Then the whole family should change to a low carb diet, 40 to 50%, not more than that. The diet, whole thing should change, and take the vegetables and all first, and then only the grains and the carb. That is another thing. And IGF 1, please do. If it is high, it may say that it may be something which has something to do with the hypothalamic or pituitary. I think that's all. Next. Okay. Dr. Dunia has done a good job. I think I must congratulate her for making this huge effort. And Dr. Dali, Dr. Suresh, and the whole team, Kottayam team, under the leadership of Dr. Shanavas, has chosen a very good case. I think we should be, nowadays, wherever I am going for DNB exam, some staff's child will be brought, staff nurse's child may be brought there as an ambulatory case. And I find that most of them are having obesity. I'm very happy to discuss obesity. And I asked what is junks, the student doesn't know. They say weight is more, but they have not taken the height. They don't know what is the importance of height. So I'm very happy when I see most of the staff need ambulatory cases, ward rounds, etc. So they bring all these staff's children who are really obese. And I like to discuss this. And we are sitting on a volcano of
Madam, you are not audible.
Madam, connection boy on സംശയം. Dunia, can you stop the sharing?
It is stopped.
Elizabeth Madam, last പറഞ്ഞത് കേട്ടില്ല.
Madam, ഇടയ്ക്ക് audible അല്ലായിരുന്നു madam.
Maybe my internet is getting.
Some problem.
So I was telling that staff children will be brought for ambulatory case, and most of them are obese. And I like to ask them about obesity, junks and all. And most of them have no idea about what is obesity, what are the complications, etc. And then we are sitting on a volcano of obesity and a pandemic of NCDs ahead. So further, there will be no money for women and mother and child, etc. Only for cancers and NCDs. The government will have to make so much of dialysis units and all that. So start focusing on obesity. Very nice that you have chosen this.
Thank you, madam.
Always with the SAM and all those malnutrition to answer most of the difficult to do, but that's why I chose obesity this time. Always, madam, you
Great.
And it was a very extensive session, and almost when beyond 1.5 hours also. And I think Dunia has reasonably worked the case well, because she had a nice presentation also.
Usually, when do you stop? When do you stop? Usually 9 o'clock.
Usually 9 o'clock. Okay. Shanos, do you want to add anything? Shanos, sir, are you there? Yes.
Dr. Shanavas.
Shanos ഉണ്ടായിരുന്നു.
Yes, very much, sir, very much here. Okay, I have enjoyed very much, as if madam, we used to listen to madam in our UGs and PG days. And thank you very much, madam. Very informative discussion. So many points. I am writing everything, madam. Thank you very much, madam.
That is
Same, madam.
why I asked her to make a diet. So
Yeah.
don't make, the whole family will have to change. The whole dietary pattern will have to change. With this, similarly, we can't manage Sam with the idli, sambar and all. No, we'll have to go for the therapeutic diet. Then with that, we can't manage them. We can't meet their energy sources. Here, you have to completely change the diet.
Anyone want to ask any question particular?
Purushottam sir was not there this time. That's
Like,
why. That's question.
Dr.
No, no.
Aarti Kenetkar from Pune has joined and she's typing in the
There are
chat.
so many persons from outside Kerala. So many.
Ah,
Many from outside Kerala joined, madam. Many from outside Kerala also joined.
I usually join when madam is around. And every time.
good luck.
Thank you, madam.
Okay, we'll. Dr. Danya Sridhar is writing. Okay, we'll leave. Good night.
Okay.
Right, madam. Thank you, madam. Thank you so much.
Nice session.
Please,
Thank you.
please keep me posted about his progress. And
Okay,
if you
madam.
can do these
Definitely, madam. Definitely.
2-3 investigations, that may help metformin whether we want to start or not. Huh?
For this, I got afraid. That is why.
Eh?
What to say. When I saw the case in the OPD, I got afraid. 96 kilo man standing in front of me, and what that day should be given to him. So actually, I was,
And you must
afraid.
handhold. Huh? If you tell all the complications, they will run away from you. But you must tell that let us work together. Some hand holding should be there. Otherwise, they'll run away. Okay, bye.
Now actually, child feels that he wants to reduce the weight, and actually there is a thought from his side that he wants to lose some weight and become a normal size.
Then he has conquered it 50%. Self-realization means he has conquered it 50%. Very positive. Very positive. Okay.
Okay, madam. Thank you.
Okay, madam. Thank you.